And the
Red
music,
button.
Say that again. Oh, the music. Oh gosh.
the non-copyright.
Oh god. I don't know how to I don't know if that's gonna happen.
If
Where'd
you
it go?
don't have it, that's okay.
It's there, but I have to start playing it.
You might need to share sound with like the Zoom
I
option.
think that I'm doing that.
Oh, wonderful.
You can hear something.
Very upbeat. I don't know if that's too much. Make it lower.
That's
Okay,
great.
great. Oh, no.
It's going to end up on YouTube.
Oh no, it won't be on YouTube. No, that's just for the, no, we won't be, I'm not even sure what we're gonna do with the recording, but we just wanted to have it just in case people weren't able to attend. Sometimes they ask for a recording, but it won't be posted anywhere or anything like that. And we'll let you know.
Probably be sharing as a Google Drive link maybe, but it won't be for online publishing.
Yeah. Okay, let's see. Should I admit people?
That sounds good.
Okay, perfect.
Hello, everyone. Thank you so much for joining us on this fine Saturday morning, afternoon, or evening, depending on where you're zooming in from. My name is Chinmayi Belusu. I'm a second-year undergrad student at Columbia, and I have the honor of moderating our wonderful speaker discussion and presentations today. Before we get started, I want to tell you very briefly about the Journal of Global Health and Simply Neuroscience for hosting this collab panel, and then dive into a couple of quick housekeeping notes before we get started, diving into our speaker bios and more. So the Columbia Undergraduate Journal of Global Health is Columbia's premier undergrad-run public health publication and media organization dedicated to publishing original student research relevant to the broader global health community. Their aim is to convey the diverse perspectives necessary to address global health challenges and bring about equity in healthcare for all worldwide. Other organization today is Simply Neuroscience, a student-led nonprofit organization dedicated to expanding interdisciplinary neuroscience education, outreach, and awareness. I would just want to shout out the Journal of Global Health and Simply Neuroscience team members. If you want to wave, say hello. There they are. Wonderful. Diving into a couple of quick housekeeping notes. This event will be recorded. So if you do not want your face or your voice to show up in the recording, please keep your camera and microphone turned off. Everyone should be muted by default due to Zoom settings. But if you at any point find yourself unmuted, please mute yourself again. Since we have a large audience here today, we want to make sure that we don't pick up on any background noise. With that being said, Alyssa, do you mind advancing the slide? Let's get started, learn more about our speakers before they dive into giving us some brief presentations about their work and their journey. Then we'll be diving into a Q&A session with both questions that you submitted previously through the registration form, and even on the spot, feel free to drop them in the chat and we'll be covering them. So with that, first we want to introduce Dr. Chin, who's an adjunct professor in the Department of Neurology at the NYU Grossman School of Medicine, as well as a visiting faculty member at Mulago National Referral Hospital in Kampala, Uganda, and the Muhimbili University of Health and Allied Sciences in Dar es Salaam, Tanzania. In 2012, he founded the Alliance for Stroke Awareness and Prevention Project, a student-led volunteer initiative providing free and community-based screening and counseling for high blood pressure and diabetes in Uganda, Tanzania, India, and Nepal. Dr. Chin's clinical research interests include the determinants and prevention of stroke in low and middle income countries and central nervous system tuberculosis. Dr. Chin, if you'd like to wave and say hello, we're super, super thankful to have you with us today. Next slide, please. Next, we have Dr. James Giordano, if you'd also like to wave and say hello. He is a professor in the departments of neurology and biochemistry, chief of the Neuroethics Studies program, co-director of the program in science and global health law and policy, as well as chair of the subprogram in military medical ethics of the Pellegrino Center for Clinical Bioethics at Georgetown University Medical Center. Among his numerous other titles, Professor Giordano is the author of over 300 papers, 7 books, 21 book chapters, and 25 government white papers on brain science and ethics. I'm really, really thankful to have him come in today. Next slide, please. Next up is Dr. Sarah Tom, if you'd like to wave and say hello as well, there she is. She's an assistant professor of epidemiology in the Neurocorps division of the Department of Neurology at the Vagelos College of Physicians and Surgeons, as well as the Department of Epidemiology at the Columbia Mailman School of Public Health. Dr. Tom's primary area of research uses methods of demography and epidemiology to study risk for and resilience against dementia and cognitive decline in older adults from a life course perspective. She's particularly interested in leveraging existing sources of data and in applying formal demography methods to epidemiologic studies. Dr. Tom's work also examines modifiable risk factors for and consequences of sleep health in older adults and prescription drug utilization in the Medicare population. Thankful to have you join us as well. Next slide, please. And last but not least is Dr. Nirali Vora. There. She's a clinical associate professor of neurology and neurological sciences at Stanford University. Dr. Vora also directs the Stanford Global Health Neurology Program, through which she started the first stroke unit in Zimbabwe and gained experience in HIV neurology, as well as other neuroinfectious diseases. Additionally, Dr. Vora serves as the director of the Stanford Adult Neurology Residency Program, and through her work, she has focused on vascular disorder treatment, stroke prevention, and strategies for achieving and implementing equitable healthcare. We are so excited to welcome everyone here, our wonderful 4 speakers. And we're going to get started by Dr. Chin kicking us off with a slides presentation discussing his work. Over to you, Dr. Chin.
Great, thank you, Alyssa. First, let me start off by thanking everyone for joining, and a shout out to all you graduating medical students who matched this week. Very exciting news, I'm sure, for many of you, especially those who went into neurology, which is the best specialty in medicine. So that's why we're here today. I'm going to share some slides and tell you about my work. The introduction was very nice. I appreciate that. So with that, let me start my slideshow.
Unless I think you might need to.
Yeah, I need to share screen. Let me share my screen. Okay. And is my screen sharing?
Yes, sir.
Okay, wonderful. So that's me. I've been involved in global health and global neurology for about 12 years now. I am on the faculty at NYU. And here's a little slideshow of my work. In New York, I am on service at Bellevue Hospital 4 weeks a year. This is my neurology consult team last June, just as the first wave of COVID was settling down. And I love Bellevue Hospital. Bellevue Hospital is basically doing global health. We have probably half of our admitted patients are persons from disadvantaged populations, homeless people, immigrants and refugees, people with multiple comorbidities, many non-English speaking patients. And we have diseases that are just diseases that are global. And I love working there, and I'll be there in 2 weeks. So looking forward to being back in New York. As mentioned, I have been on the faculty at the National Hospital of Uganda and the National Hospital of Tanzania for the last 10 years. Twice a year, I spend 2 months a year teaching bedside clinical neurology at these two hospitals. Each visit, I bring one of my senior NYU residents for a 1-month clinical elective, and they are extremely useful. They challenge themselves. This is one of our residents, Jake Pellinen, teaching at the bedside. 95% of all of my global health work is about education, and it's all bedside neurology teaching. I have no research grants. I do no controlled studies. All of my research is clinical observational research that happens during my teaching. My personal goal in global health is to improve neurology education and improve neurology capacity in developing countries. Most of these countries that I work in have very few neurologists, and in Uganda and Tanzania, actually all neurology patients are cared for by non-neurologists who are pretty much self-trained. And when I go there, my job is to teach basic clinical neurology and help the doctors there do the best they can with what they have. This is my colleague, Jay Bott, who is also at NYU. He and I run the global neurology program in the Department of Neurology at NYU. And here he is with a group of students teaching them how to do a basic neurology exam. There is no formal neurology training program in Uganda, and the students there are just amazing. They love learning. They love anybody who's going to teach them anything. And since neurology is a real gap there, when we show up for a 1-month clinical rotation, we're just teaching all day long. We work every day, Saturday and Sunday. And it's really rewarding to see these students appreciate that neurology and neuroscience is exciting, and they get over the fear of neurology, which is a fear that exists everywhere. This is one of my residents, Aaron Rothstein, who came with me to the Dar es Salaam hospital last year, and we had a wonderful rotation there. They do have a few neurology fellows there who are medicine residents who have decided they like neurology. And I mentor these fellows now and help them with some of their research projects. I have been able to go to Tanzania during the pandemic. I went to Tanzania in November. If you've been following COVID carefully around the world, there are 3 countries that have pretty much denied COVID and have stopped reporting. Those include Tanzania, North Korea, and I believe it's Turkmenistan. Tanzania has been open to all visitors with no quarantine, no testing since last June. And I went there in November, showed up at the airport, got off the plane, and that was it. And I'll be going back there next month for another 1-month teaching visit by myself, since still residents are not allowed to travel globally. These are my 3 medical residents who worked with me last November. And in Africa, actually, the majority of medical residents are female. When you work in these countries, we use the term resource limited healthcare. Drugs are few, tests are few, healthcare personnel are few. This is my resident, Aaron Rothstein, with one of the staff physicians. We're doing a lumbar puncture. There are no lumbar puncture kits, and we improvise. And we're measuring the CSF pressure with a piece of IV tubing that we cut with a scalpel and attach to the end of the lumbar puncture needle. There's limited health care for emergencies. This is a patient of ours with a cerebral hemorrhage in Uganda, and she was starting to herniate. We called the neurosurgery resident in at 7 p.m. and at the bedside, not in the operating room. The power went out in the hospital. There was no light. She did a burr hole at the bedside while the rest of us provided lighting with our flashlights. You learn an amazing amount about tropical diseases. This is a young boy with Burkitt's lymphoma in Uganda, which is endemic in Africa. But the truth is, all diseases are global. We are no longer living in isolation. Every disease in the world is in every country in the world. And I teach my residents at Bellevue that everything is on the differential diagnosis. And they know tuberculosis is my favorite disease. Almost every patient we admit, I put tuberculosis on the differential. Infectious disease outbreaks, as we know, are now front and center. We are now all very aware of infectious disease outbreaks. There's new Ebola outbreaks currently going on in West Africa. And one of the biggest things you'll learn, which we have here, we have it everywhere, but in many countries, stigma and discrimination are extremely concerning. And, you know, in neurology, probably the biggest stigma is epilepsy. In most countries, epilepsy is still considered a psychiatric disease. And in Africa, most people with epilepsy are felt to be possessed by demons. This is a young lady with epilepsy, which we actually diagnosed by this picture, because in poor countries, people with epilepsy, they have a seizure, they fall down, and they burn themselves on the fire pit on the floor of their homes. But then you also have to realize that in many parts of the world, Western medicine, allopathic medicine is not the first choice. Traditional healers are everywhere. We don't discount them. We have to work with them, although in some cases it's extreme. This is a young woman who became paraplegic, and she went to a village doctor who proceeded to cut her legs with a scalpel, with a razor blade, hundreds of times, promising her that the razor blade cuts would cure her paralysis, which it did not. And you know, my main interest is teaching neurology, but my public health interest is preventing neurological disease. And as mentioned, I started a nonprofit charity in 2012, where in Uganda, Tanzania, India, and Nepal, I have students, medical students and nursing students who are out every week at churches, temples, and mosques providing free screening and counseling for hypertension and diabetes. So that's my story. I love neurology. I love giving back. And again, my goal is to try to improve the care of neurology patients worldwide. I hope I didn't take too much time. Thank you very much, and I look forward to your questions.
Thank you very much, Dr. Chin. That was perfect timing and really great to hear about not only intersection of medicine and public health, but also you touching upon cultural differences and how we can also work to bridge that and work together in that avenue. Next, we're going to have Dr. Giordano present. Over to you, Dr.
So I don't have screen sharing capability. There we go. Very good. Let me know when you're able to see this. Got it?
Got it. Thank you.
Good. I've been told I have a great face for radio, so there's absolutely no reason for you to see my face while I'm going over my slides. So what I'll do is let you focus on the slides. You know, as Dr. Chin mentioned just before, we're talking about ever more global communities, contemporary technology, not only internet technology that's given us ubiquitous information and information availability, but the technology that allows us to move relatively freely, coupled with technologies that are also inflictive technologies that prompt things like forced migration. So as a consequence, more and more, we're becoming a global community. And if we take a step back from some of the work of my clinical colleagues, the work then becomes, well, how do we inform these practices of neurology? And very often, the direct translation from the proverbial bench to the bedside and the bedside beyond that which is proximate into the bedside worldwide is a function of translational neuroscience and technology, which we refer to as Neuro-S&T. So what I'd like to do is I'd like to give you 10 major points that summarize the past 20 years of my group's work. And of course, my work is funded by a number of different resources, most notably the National Institutes of Health, National Science Foundation, the MacArthur Foundation, Hastings Foundation, a number of others. And I'd like to really give a nod to some of the international colleagues with whom I've worked, because you really can't do any form of global science, technology, biomedicine, and ethics without international colleagues. I think the adage is nothing about us without us, and it obtains. It becomes very important to conjoin their participation, as Dr. Chin very well alluded to, and definitely explicated in his presentation. So some of my ongoing collaborations have been with my colleague, Dr. Roland Benedicter from URAC in Bad Tölz, and also in South Tyrol, Professor Dr. Nico Kohls, the Program of Global Health Promotions in Coburg, Germany, my longstanding colleague, Dr. John Shook from the University of Buffalo, Dr. Dan Stein from the University of South Africa, and Dr. Tachibana Koji from the University of Tokyo. But there are others who are working in this field whose work I should direct you to. People like Dr. Karen Rommelfanger, Dr. Karen Herrera-Fera, Dr. Arlene Salas, Dr. Katinka Evers, all are working deeply in the idea of a globally translational and perhaps viable neuroscience and the ethics that goes with it. So let's work from premise to a logical conclusion that throws forth, if you will, the gauntlet of both challenge and opportunity for each and all of you who are in the audience, particularly those of you who are students. Recognize that, as you certainly gained from our first speaker and from our other speakers, that the idea of biomedicine written large on the global scale conjoins not only clinical practice, but research practices, and not only the life, physical, and natural sciences, but the social sciences as well, inclusive of the humanities, education, and law. So what it really does is it throws down an invitation to each and all to participate in the opportunities and challenge that a globally relevant health promotions oriented towards neuroscience and neurology might offer, which is our first premise, is that neuroscience and technology, what we refer to as Neuro-S&T, is a multinational enterprise. Now, the majority of that is being conducted in developing nations, but ever more, we're seeing developed nations interacting with developing nations, as you heard from Dr. Chin's presentation, and more, they're affecting both developing and non-developed nations in ways that engage cooperation, and in some cases, competition, and in other cases, asymmetries of capability that create some distinctions between the neuromedical haves and have-nots. Well, as soon as you begin to get that diversity, this then necessitates acknowledgement, at least, and appreciation, and a deep appreciation of cultural similarities and cultural variances. And that's important because understanding the different histories, needs, values of cultures, where they intersect and where they don't intersect, provides a mechanism that affords insight into what may need to be done to develop relevant health care in neurology and more broadly, general biomedical care that in a way is going to be sensitive to those things that are cultural values. But there's more, because this non-identicality of culture can certainly undergird not only different cultural histories, values, needs, philosophies, but growing from those philosophies, differing ethics. And those differing ethics can then create different tolerances and allowances for different aspects of research, development, testing of techniques and technologies, and use in a variety of different ways in medicine, in public life, and even in political ways. And it becomes important to understand how those differences and similarities in cultures may prompt differing ethics to gain a more intuitive understanding of what those ethical differences and similarities may mean. Because those differing ethics that allow distinctions in research, development, test, and patterns of use also increase the viability, if not likelihood, for two very important dimensions. One is something called research tourism and leverage, and the other is medical tourism and leverage. Let me explain. In other words, if we're in country A, and country A has particular ethical restrictions on what you can and cannot do in research, but country B does not, well, then very often what you might find is that researchers may in fact travel to country B to get certain things done. And in some cases, that level of travel is actually solicited, if not directly attracted, so as to increase countries B research capabilities and therefore offer services on the global stage that then attract patients and solicit patients worldwide. Come to country B, so to speak, because you'll be able to get A, B, C, X, Y, Z that you can't get in your own country. Now, at first blush, there's really nothing wrong with that, but then it also speaks to how we deal with differing ethics. In other words, if there's certain things we can't do here, but they can do somewhere else, and that then becomes useful on the global scale, well, how do we then regard the ethics if they're different? If the methods used to get to those ends were not things that we're ethically aligned with? Do we reject them outright? And what does that mean then for individuals being able to travel worldwide to get the medical treatment that they not only need, but evermore that they want? In other words, can they gain neurological services, neurological techniques, inclusive of the use of cutting edge technology to not only treat disorders, conditions, and injuries, but perhaps engage some form of neurological preventive care, or perhaps even boutique care? And the reason we talk about this is critical because these capabilities that neuroscience and technology offer in medicine, public life, extend into the range of the economic and into the political. Neuroscience and technology as leveraged in medicine is a huge market, billions and billions of currency dollars per year that are viable. And this then creates what we call differing hegemonies. In other words, different areas of influence that produce asymmetries in capability and control, not only economically, but biomedically. And this is important to understand because this is what the philosopher Michel Foucault referred to as biopower. Our group refers to this as neurobiopower. In other words, being able to influence individuals' neurobiologies, the way they think, the way they feel, the way they emote, their neurological, cognitive, psychiatric health, through the offering of availability of products and services and understanding what those offerings or restrictions may mean. So what this really obligates is a globally aware and sensitive, responsive ethics. Oh, I apologize for the typo. That aware in ethics really needs to recognize that there are a number of countries, developed countries, and increasingly developing nations, and perhaps even non-developed nations, whose histories, whose values are becoming ever more important in the conduct of global activities. Understanding, for example, diversity as well as understanding inequities that exist on the global stage is paramount. But, perhaps we need to move away from just a Western orientation, particularly as our international colleagues gain in their capability to influence economics, if not the conduct of medicine worldwide. Well, if we're going to develop that ethics, you have to understand that very often ethics has a big mouth, but no teeth. Ethics informs policy and should inform international biomedical law. And ethics and policy should work reciprocally to both assess risk and to mitigate risk in those key areas of neuroscience and neurology, whereby we can maximize the benefit of what we're doing in ways that are sensitive to how different people define goods, and also reduce risks, inclusive of the risks of potential harms or burdens, and/or diversity in the way individuals view goods or harms. And what this really means is that ethics and policy must be temporally relevant and responsive. In other words, it's not just a question of looking backwards and saying, well, what mistakes did we make? Yeah, that's important. But we also have to look to the present and into the future. And we look to the future given the metric of the progress of brain science itself. Right now, as I speak to you in 2021, things move from the laboratory bench to the bedside in neurology in about a 60 calendar month period. That's very fast. That's 5 years, going from some concept to a usable construct as a tool or a method. And more on the global stage, the measure of that is that there's international cooperation, collaboration, and in some cases, competition, which is driving the science and technology forward and the uses of the science and technology ever more forward. So we have to be relevant to these timeframes, where we are right now and where we'll be in 5 years. This is the zone of probability. Where we'll be in 6 years to 15 years, that's the zone of possibility. And where we'll be 15 to 30 years in the future, and that's the zone of potentiality. And understanding who's doing what they're doing, how that's going to affect not only biomedicine locally, but biomedicine globally becomes ever more critical. And these discussions shouldn't just be discursive. In other words, it's not just talking. It really is an active process called dialectic, whereby we recognize that views may differ, and we employ techniques to be able to align certain views, gain consensus on certain views, but also appreciate dissensus and what that then means. Where is it okay to differ? And where we do differ, how can we then come together? And this then works towards a new global posture, a posture that is both cooperative and what is referred to as cooperative. In other words, competition. Because as we move forward, what we're really trying to do here is untangle this Gordian knot of how the brain works. Folks, I've been a neuroscientist for going on 40 years this year, and I can tell you, we've learned a lot, but there's a lot of things we don't know. And our science and technology, working with our international partners, is helping to unravel this knot. But the thing we don't want to do is unravel the Gordian knot of the brain only to open a can of worms on how we'll utilize this brain science on the very diverse global stage of the 21st century. If you're interested in ongoing work of my group in collaboration with others, I provide that information for you here. These are some of our recent publications. And if you're looking to get in touch with me after this, if questions come bubbling up, as I hope they will, because this sort of incubates them, feel free to get in touch with me. You can reach me at james.giordano@georgetown.edu. Thanks very much.
Thank you so much, Dr. Giordano. That was really great to hear. I know that many of us in the audience are neuroscience or pre-health students. And I think that kind of the ethics and thinking about what are the later implications of research that we're performing now and into the future, it's not something that's really touched upon as much in the classroom. So it's really great to hear about your work and perspective.
Very good.
Thank you. And next we go over to Professor Tom.
Hi, everyone. I'm Sarah Tom, and I am a demographer by training. In the field of demography, we focus on fertility. So this is number of children born per person, mortality, and migration, and how these forces influence population size and distribution of characteristics in the population. My current research focuses on understanding how social experiences over the life course influence the risk for Alzheimer's disease and other dementias in later life. So I'm in a pretty unique position having an appointment in the School of Medicine. There aren't a lot of social scientists who have appointments in a department of neurology. I'm in a unique division where our goal is to use our expertise in theory and also with data and analysis to work with our clinical colleagues to help take their expertise from clinical care and translate those questions into testable hypotheses. Much of my work focuses on the United States, but coming back to a point that Dr. Chin made about the US really becoming reflective of global health, is that in the US, we see a diversification of the total population as well as the population age 65 and over, which is the population we tend to think of being at greatest risk for Alzheimer's disease and other dementias. And in particular, we see the fastest growth among the Hispanic and Latinx population overall in the US population, and that's also true for older adults. With this diversification, I wanted to come back to something Dr. Giordano mentioned, which is about the importance of involving communities. And as we see this diversification of the US population, I feel that it's imperative to make sure that we involve people from these communities in our research, and also that we create opportunities to make sure that our workforce of scholars who are engaged in research and clinical care is also diverse. So I want to turn to this photo for a moment, and this is my grandmother, and she has been someone who has been very important to me over my life. And this also reflects what I study in my research. So I'm interested in understanding how do social experiences over the life course influence the biology that then translates into cognitive decline and dementia risk in older adulthood. And so we could think about experiences that happen in early life or midlife that directly impact brain aging in older adulthood, or we could also think about how social experiences in early life might influence social experiences we have as midlife adults and older adults, which ultimately influence dementia risk. So let's take a moment and talk more about some examples from these life course stages to understand why these are important when we think about dementia risk. So in early life, which is here, we can see a picture of my grandma when she was 3, the brain develops very rapidly, particularly after birth. And so we can think about people who start life with advantages with their brain development might have advantages for the rest of their life that influence cognitive aging. And the brain develops hierarchically in terms of skills. So by the time we are about 12 to 18 months old, we have begun to develop skills of sight related to recognizing shapes. And then about a year later, we start to use those skills to recognize emotion in the human face. And so again, we can think about someone who has really strong development early on, that then the skills that build upon those foundational skills might continue to be strong throughout life. And those who have disadvantages and who might have a slower start to that early development, that they may experience a lag, that there might be some catch up, or perhaps that this is a disadvantage for the rest of the life course. In particular, because of this accelerated time of brain development, there has been some recent effort focused on understanding how adverse events in early life influence brain aging. And as the brain develops, there's a hypothesis that how the brain learns to respond to these different stressors early on, that will shape the way that the brain responds for the rest of life. We can also think, moving out of childhood and into adulthood, we can think about other social experiences that might influence dementia risk later in life. And education is one of the strongest predictors of dementia risk. Those who have higher education and higher quality of education are less likely to experience dementia and are more likely to experience a slower cognitive decline in older adulthood. And we can also think about how one's own education might be related to early life experiences. In particular, your own education is very related to the education of your parents. And although currently in the United States and in many other countries, there are programs to try to decouple that link between your parents' education and your own education, if we're thinking about people age 65 and over, there was certainly a strong tie between parents' education and one's own education. Moving into midlife, there are a couple of potential biological pathways that seem to be really important for brain aging. One of those is with cardiovascular risk factors, so things like blood pressure and blood sugar levels and cholesterol. So when we think about what are the potentially modifiable risk factors for dementia, one of the number one targets is vascular risk factors in midlife. And research has shown that it is the profile of these vascular risk factors in midlife that has a stronger link to brain aging, and that this link is stronger than if we were to look at vascular risk factor profiles in late life. Another important concept when we think about how to prevent or slow cognitive aging is this concept of cognitive reserve. So cognitive reserve recognizes that there are some people who have the signature of proteins related to Alzheimer's disease in their brains, but somehow these people don't exhibit clinical cognitive decline or clinical dementia. And the question is, why do these people have the ability to buffer against this neuropathology? And cognitive reserve says that there's something about these people. One of the main hypotheses is that somehow they have, by being cognitively engaged over the life course, that they may have this ability, this extra resource that allows them to buffer against this pathology. And when we think about what are the links to social experiences, I think two of the major demographic changes in the United States in the 20th century that might influence both vascular risk factors and cognitive reserve are decreasing family size and the polarization of work opportunities. So we have seen a decrease in family size starting from around 4 children per woman at the turn of the 20th century. And now we're below 2. And so certainly when we think about women's risk for dementia, I think that understanding the role of family size is really important. Also with work, we've seen after World War II, there was this expansion in the economy and in employment opportunities. And then there was a global recession in the 1970s. And since then, we've seen a decrease in the number of jobs available related to manual labor and an increase in jobs related to the knowledge economy. And so those two demographic changes might have implications for vascular risk factors. We could think about things like stress or physical activity that happens in relation to taking care of families or on the job. And we could also think about how income and the ability to not have to work 7 days a week, for example, might also influence vascular risk. And of course, with cognitive engagement, the skills demanded in the job might influence cognitive engagement. And also with family size, the jury's still out about how smaller family sizes might influence cognitive engagement. And then moving into older adulthood, one aspect I wanted to touch upon in terms of social experiences is actually getting a diagnosis of dementia. And we think about different reasons why people might be diagnosed earlier or later in the course of their cognitive decline. Certainly stigma for a variety of reasons, including cultural reasons, might be a factor, and also access to care may be a factor. Over the last year, because of COVID and other situations that have happened in the US and abroad, I think we become more aware of the importance of inequality, discrimination, and trauma over the life course. And I think that we're just starting to understand how those relate to dementia risk. Finally, I'd like to end by offering that the life course perspective also is an important opportunity to understand, why are people resilient to dementia? So what are the things that help people age gracefully? In the case of my grandmother, she was someone who had a lifelong passion for education. She was still taking classes at community college into her 90s. And she was also someone who really enjoyed life, who loved to try different foods, and who made sure to have a little bit of dessert every day. So with that, I'll close and welcome any questions that you might have later on.
Thank you so much, Professor. It's really, really interesting to hear about so many different factors coming together in your work, from the social to the economic to the biological, and all seeing the effects of that, not only historically, but also trickle down into the present, is really fascinating. And thank you for sharing your grandmother with us as well. With that, we'd love to move on to Dr. Vora's presentation.
Hi, everyone, and thanks again to all the organizers for including me. So I'm a stroke neurologist, as you heard, and just to make sure we're all on the same page, right? A stroke is when there's inadequate blood flow and oxygenation to the brain and can lead to disability. It's actually the #1 cause of disability worldwide, and it's a leading cause of death, particularly in sub-Saharan Africa and other resource-limited settings, although the overall mortality is going down in other higher resourced areas. It remains a major issue and a preventable one, as you heard from some of the other speakers, when targeting high blood pressure or high cholesterol. And so this inequity in stroke mortality was really important for me as someone interested in global health. And because I am a subspecialist myself, I turned my focus farther away from the primary prevention, which probably does give you more bang for your buck, which is like preventing, the health screenings that we were hearing about, or even primordial prevention, which might be more focused on health policy and sort of social determinants of health. But as a specialist in this area, I focused on secondary stroke prevention, which is really taking people who have already had a stroke or already have risk factors that have come across and trying to prevent them from having future events. And that's important because of people who have a stroke, probably 1 in 4 of them have actually had a prior event, and it's a great opportunity, and it's important in global settings as well. And so when I got involved in global health, I actually didn't know what to expect. I didn't actually set out on this journey, and when I was asked to come to Zimbabwe first, at the Primary Natural Hospital in Harare, Zimbabwe, there was a need and an understanding that stroke risk was high, but not exactly a clear answer on what we're supposed to do about it. And what transpired in retrospect was actually really highlighting the importance of sort of a design thinking process to get at solutions in global health. And so I hadn't planned to prepare slides, but I'm actually I just pulled up an old talk, and I want to show this design thinking framework, because I think it's really important, as all of you set out and think about, hey, what do I want to do in global health, that we're really careful not to assume the solution, but to actually think and work collaboratively with your partners locally and think about how you can make a sustainable intervention. And so we can come back to this picture in the end, because this is a result of what I'm going to show now. So give me 1 second to see if I can pull this up. Do you see this framework? So this is actually from the Stanford Design School and business schools and biodesign programs. And I'm sure there's some engineers out there too, and you may have seen something like this. It's since been modified, so this is sort of an older figure, but I think it's important because it actually gives you this framework about building empathy, defining, what the needs are in a space that you're aiming to work on, thinking of, many ideas and brainstorming, and being really open to creative ideas and options for how you can tackle a particular need. And then building a solution, which, in medicine sometimes is a systems change rather than an actual product, but could be a product. And then really testing it and being open to iterating this so the cycle can continue. And I think that, needs finding is so critical, and it's often a skip step in global health. This kind of focuses on empathy, and what do I mean by that? It's really that if you want to innovate in global health, you really need to know who your population is, who your users are. So again, this is like in design speak, but caring about their lives and doing so through thoughtful observation. And that was the first lessons I learned, when I went up to a resource limited region, was to really sit back and observe actively and passively. and understand what is going on here with stroke for me specifically, which is what I was tasked to do. And, you know, eliminate my own personal biases about how stroke care is established in America or in other places, and listen to stories and listen far more than you would ever talk. And to also listen to what a person is telling you, which might be like, yeah, every stroke patient gets a CT scan, which is a technology used to differentiate a lack of oxygen to the brain because a blood vessel has burst and is bleeding, or a hemorrhagic stroke, or that there's an absence of blood and the person is having an ischemic stroke because there's a blood clot preventing blood flow into the blood vessels that feed the brain, into the tissue that goes to the brain. And so while someone might tell you, yeah, and then the stroke patient gets a CT scan, you have to see what's actually going on. Oh, the CT scan is broken here, or this person can't afford a CT scan. And so people are saying one thing, but there are workarounds happening to manage the current resource gaps. And so this kind of empathetic observation and thoughtfully asking questions and interviewing all the stakeholders involved in a particular issue is really helpful to getting at what is the need. Again, not the solution, but what is the need here? What is the real issue? Why is stroke mortality high in this particular environment? And so, you know, there are some ideas here at the bottom. It looks like this is frustrating. Like, what are you actually trying to do? And I think for many of you that are pre-med and going on to becoming doctors, there's a tendency to want to treat the problem, to come up with the answer. And that's not the best method. It's really about understanding the context before you can get to a sustainable intervention. And so in this particular situation that I was in, what I observed was that the medications for stroke prevention, like blood pressure medications, aspirin, if it's a loss of blood flow type stroke, ischemic stroke, cholesterol medications, you know, all that was actually available to those that came through the hospital and were quite affordable, but were not being used. And why? And that was part of what this needs, you know, finding, observation, empathy building was. And it was not being used because if you don't have a CT scanner and you can't figure out if the person has had bleeding, there's a fear that you would do more harm by starting the person on an aspirin, which is a blood thinning type medication, and that you could cause problems. And therefore people just sort of had variable practice in what and how they would care for a stroke patient once they were admitted to the hospital. And some of those things led to complications that ultimately led to death or worsening disability. And so because of, you know, the limitations in getting imaging, which had to do with cost, quality, and access, couldn't figure out if it was a bleeding, hemorrhagic, or a loss of blood flow, ischemic type of stroke. And then there was sort of this paralysis. And so what I felt after my time initially was that, you know, and very much working with the partners that we had there, physicians, nurses, radiologists, ER doctors, and there's actually no neurologist in this location. There was somebody, Dr. Nwende, who is extremely passionate about neurology and could basically be called a neurologist, though had not had training in that area. And so really working with all these partners to build this needs assessment. And I love this quote from the design school, that framing the right problem is the only way to create the right solution. You have to know what the problem is first, and it's quite complex. But for me, I came to the conclusion that with stroke being such a common cause of death and now the leading cause of disability, with projections to rise rapidly in lower resource countries, as well as a high rate of mortality, that, you know, that's the fact. And that what I observed was that there was variability in the stroke management despite the availability of medications. And so the need then was to standardize, you know, care for the patient after the stroke has happened in the absence of a CT scan or other resources in an effort to reduce mortality. And so with that initial framing, I was able to proceed in thinking about what to do and coming up with ideas. It's not about coming up with the right idea. It's about generating the broadest range of possibilities and really talking with people, hey, is there a way we can do this safely where you don't have the CT scanner? Can you start aspirin without imaging? How comfortable are you with that? Let's have these conversations. And I'll spare you all the details, but since this time, there have been papers that have come out that show, that it might actually be overall potentially safer to start aspirin even without a CT scan if the person's not in a coma and enough time has passed. And the reality was the majority of patients who were coming in with strokes to that hospital were coming in after a couple days, had traveled many hundreds of kilometers to get care at the main, teaching hospital in the city, and therefore wasn't at the same type of risk of worsening bleeding by starting aspirin, earlier on in their course. They had sort of settled out. And so then we went into this prototype phase, right? We wanted to build solutions or parts of solutions so that we could think and test and learn from our ideas. And again, this is from the design school to give some ideas about how to move forward in this area. But what we ended up doing is looking at the literature that, people sometimes ask me, oh, you work on stroke units in resource limited areas. So like, do they have IV TPA, which is the clot busting medicine you give right when somebody is having a stroke within, 4.5 hours? And I'm like, whoa. I'm like, no, patients aren't presenting within 4.5 hours. I'm talking about keeping patients who make it to the hospital days later, keeping them alive, and then figuring out how to prevent future strokes. So we need to kind of shift and really think about how do we target that area first, and then move backwards to kind of modern treatments that are available here. And so there's this idea of the stroke unit, which is really just an organization of stroke care, multidisciplinary, that physically brings together stroke patients to one part of the hospital. And what I had observed at that hospital and many hospitals that I've since worked at, that patients are sort of scattered throughout the various units, and that there wasn't really one place to have all the stroke patients together. But data shows that bringing those patients all together in the same place allows for standardization and more algorithmic care that allows certain checklists to be made and a certain quality of care that can move forward then and implement things that we know are life-saving, like certain medications, rehabilitation, and education for both, the patient and their families. And so again, without getting into all the details, it became clear that this was actually a low-cost, effective intervention to shift the resources around and simply, really was more of a negotiation between different parts of the hospital to allow patients to move around and come together in one physical space, and then develop some protocols that would work within the bounds of the resource limitations to allow for this care to be delivered in that unit. And so it was through many subsequent trips with my trainees as well, and with partnerships, that the stroke unit was born, and has since been, continued by our local partners there, supported by the Ministry of Health. And I was then able to go to some other countries and do similar work in Kumasi, Ghana, and most recently in Kigali, Rwanda. Again, never jumping in with my solution from this area, but really, taking this framework and figuring out how to adapt it to the needs that were in those regions. And what has resulted has been different in each location, but has shared some of the same backbone. And so really, this is just getting at the testing part, which we already talked about, implementing a stroke treatment algorithm that was independent of imaging. We used checklists, a lot of education and incorporation of stakeholders, therapists, and the government. And so I'll just skip this and remind you of that model. And maybe you could put that picture back up, and I'll just explain that, so much of this work had unintended consequences as well. And one of them really had to do with capacity building in neurology, which I think Dr. Chin already touched on a little bit. But a few things were happening. Essentially, by creating a stroke unit, it became almost like a little neurology world that didn't previously exist. And those that rotated through it during their training then got this focused neurological exposure and really inspired people to want to pursue an interest in neurology more, whereas before it had kind of been scattered. So this allowed for there to be more and more individuals who, in Zimbabwe and some other countries that I've worked in, there isn't really like a neurology residency, which is where you can get the subspecialty training. It's sort of like you do internal medicine. And if you can find an opportunity outside of your region, perhaps then pursue some sort of advanced fellowship training in neurology or the neurosciences. And this basically got people open to even thinking about that possibility, and then working with others who provide that education in nearby centers and partnering with other institutions to get the advanced training. And so in this picture, that's Dr. Monteruse, one of the registrars or residents in Zimbabwe that I had worked with on several occasions of going down there. And we actually decided to submit the project as an abstract to the Consortium for Universities in Global Health, which I think Columbia might be a part of. And they have a great annual conference. And so we were able to raise funds for Dr. Monteruse to come to DC for this conference. And it was really eye-opening, I think, what he shared with me, that, this is the research that's being presented. I could easily do that, and I'm interested in pursuing this. And so it was just so nice to see the collaboration come full circle, whereas I was getting a lot out of the experience, learning about the systems of care and meeting people. I think that, my partners also were gaining from it by both instituting the unit, but also getting this broader exposure to what the neurosciences research is like. And so we're building that capacity. We're building people who can then take this science or take this learning and move it forward and give back to the areas they're in. And so I like this picture because it reminds me of the importance of bidirectional impact, and that collaboration, capacity building, and community building are so critical in this type of work. And I think this applies no matter what type of global health research you're doing. So I guess I'll stop there and just remind everyone that there are a lot of different approaches that you can take. And for me, this message is so critical. If you only take one thing away, what you see on the screen, as well as don't jump to solutions, really understand the problems before you try to apply solutions. Thank you.
Thank you so much, Dr. Bora. It was especially really, really great to hear about your approach to not just direct problem solving, but all the nuances along the way and how the teams really come together within, different institutions and on the ground level as well. It was really interesting to hear about. So thank you for sharing that with us. With that, we are going to go ahead and dive straight into the Q&A session now that we have all of our speaker presentations. Unfortunately, Professor Giordano had to head out due to another scheduled lecture. So he offered that if any of you have any questions directly for him, feel free to reach out at the email address he gave. I believe it was james.giordano@georgetown.edu. I can also double check that for you all. And if you do so, please write Columbia Global Health in the subject line so he knows you're coming from this event. But I would like to open it up to everyone now to, if you have any questions that came in while you were listening to Professors Chin, Tom, and Vora speak, please feel free to drop them into the chat, or if you don't feel comfortable typing to everyone, you can also send me a direct message over Zoom chat. I also wanted to get started with a very commonly recurring question from the registration form about how we can apply our education and training from maybe one country in specific to broader international and global levels. I guess one of the questions that attendees were specifically interested in is a two-part question. One is, do you believe that your medical training and your medical journey very directly gave you the experiences to think about public health and global health on broader international levels? Were there any experiences along the way that really stood out to you in forming kind of your knowledge base and inspiring you to look into this? And perhaps we can flip the order this time. And Dr. Vora, would you like to go first?
Sure, and thank you for that question. And maybe you guys are thinking, what do I do with my career to actually appropriately fit it into, the context of what your aspirations are? And I would say that I guess I had an interest in international work or global health for a long time, but didn't really know what that meant. And I had certainly had experiences before medical school, being myself first generation from India and going to rural parts of India. Or I also spent half a year in Peru and looking in the kind of the Andean highlands there at medical care. And I think I didn't really know what was going on. Like I observed, but I didn't feel that I could really be independently, helpful. And so in that way, I feel like my medical training really helped with being able to better see what the problems and that like need statement definitions were, and then have the clinical background to actually, start to think about where to go forward. So I do think my medical training was helpful in that way. I think the second thing, which I didn't touch on, is every time I go on these like rotations to the resource limited areas, like Dr. Chin, I bring trainees with me, and we're doing a lot of education to teach about neurology, because these are places where there are no neurologists. So they were sort of like a dual benefit. And I obviously couldn't teach about that particular medical field without my medical training. On the flip side, when it comes to research and, framing problems in a way that could be published more rigorously, I feel like, it would have been nice, I think, because I don't have an MPH or, an epidemiological statistical background in a more aggressive or rigorous way. I wonder, and I've collaborated with others who have it, and I feel like it's very helpful to have that additional training to think about how to do the research and spread the information in a more rigorous way. And so I feel like if you're interested in global health, it could be helpful to build that in through your undergrad or graduate training in addition to medical training, if you want to go down a more clinical route for global health. So I hope that answers the question.
Absolutely, thank you so much. Professor Tom, would you like to comment?
Sure, so I don't have clinical training, but I do want to reiterate Dr. Gora's point about the importance of having experiences abroad. So I did not have the opportunity to study abroad when I was an undergraduate. As soon as I finished my PhD, I left the United States and did my first postdoctoral fellowship at University College London. And I learned so much just about being in a different educational setting, about having to do things like set up a bank account, find a place to live. And so even though much of my work is now based in the US, I feel like those experiences just give me a different perspective. And also we have a lot of international students. And so I think the understanding of what it's like to be a scholar in a different country has also helped me be a better mentor. So I really encourage all of you who have the opportunity to study abroad or to work abroad.
I guess it's my turn. I have a lot to say, but I'm going to keep it brief. Global health is public health. Global health is really not clinical care, in my opinion. All of us in the United States have benefited from a century or more of public health interventions, clean water, vaccinations, improved nutrition, anti-tobacco laws that have improved our health and improved our life expectancy by a decade or more just in the last 30 years. And most low and middle income countries, they don't need more doctors. They need public health. They need community health. They need primary care. They need primordial care. They need vaccines. They need clean water. They need infant nutrition. So I would say if anyone on this call is thinking about doing some international work, don't think about, oh, I want to go do a rotation in a hospital and deliver babies or learn to do minor surgeries. what most of these countries need is really serious attention to public health. I often give talks about my work, and I start off by saying, these countries, they do not need more neurologists. They don't need an MRI scanner. They don't need a stroke hospital. They need affordable, accessible primary care and community care, and that's what's lacking. So I actually don't like the word global health. For those of you who've been keeping your eye on the literature in the last year, there's a whole new conversation going on about global health with regards to power dynamics, decolonization, rethinking what we're doing in global health. And we really shouldn't use the word global health anymore. We should be using the term health is global. And when I go to the countries that I work in, I go there for a month a year, a couple of weeks a year. I'm doing global health. I'm doing global health 4 months a year, but all of my friends and colleagues working in these countries, they're doing global health 12 months a year. So we need to rethink what we're doing and how we're doing it, and why. When you go and do international work, you really have to, before you get on that plane, ask yourself, why am I going to do what I'm doing? Is it for me or is it for them? Who's getting the benefit? So there's a whole big conversation going on, which we could probably do a whole different session on. And I've even had to rethink, what my real role is in this whole system.
Thank you so much for sharing, everyone. It's really interesting to hear about kind of dynamics and also getting those experiences along the way and how we can start on that journey as students just now. Another topic that you all touched upon in your presentations, and a lot of our students are curious about as well, is the role of collaboration and bringing together a lot of different stakeholders from different backgrounds in order to make the applications and outreach work and education work possible. And I was wondering if you would like to share any of your experiences in that line, how you really build those multidimensional teams along the way. If anyone would prefer to start, no order this time.
I can take that, since a lot of my work is, I think all of our work is multidisciplinary, but it has to do with just getting to know people at the beginning, I think, and having that humility. I can think of many times, I went someplace and you just, like I said at the beginning, you have to pause to give yourself 2 weeks to just sit back and meet people and understand the context and build empathy, like I mentioned. And those relationships are what help sustain collaborations. And so giving time and energy towards that are helpful. When you're just starting out, you don't want to try to go, I don't think, and create your own new thing on your own. You have to kind of look for partners that have already had those relationships to get your start, to get your practice, and to build those sustainable collaborations or work on collaborations you've already had. But you have to have those relationships, because in the end, I think, like Dr. Chin said, right, we're not there 12 months a year. We're not saying we come back, perhaps, although there are some models where you could live in that region and do the work. But most of the time, it's partnerships with your stakeholders locally that are really going to sustain a project, and you just have to have those be very strong. So, in my own experience, it was really getting to know people, spending time, and asking, who should we talk to, allowing local partners to make those next introductions. I view myself as a consultant or a facilitator. I'm not really doing much of anything independently. It's really helping those that have already, that are working in that region propel forward. So I guess that's what I would say.
Yeah, I think I can piggyback on Nurali's comments. I think the one word is trust. Wherever we go, the first thing you need to build is trust, that people know you're there for their benefit, not your benefit. You don't have any selfish motives, and it takes a couple of visits to build trust among the nurses, the cleaning staff, the students, the faculty. They all talk about you behind your back. And once they find out that you're a nice guy and that you're really serious about why you're there and you're not trying to advance your career on their backs, it's amazing how the next visit, they're like, oh, Dr. Chin, where you been? We've been waiting for you. I have so many friends now in Nepal, India, China, Uganda, Tanzania, and you know, they just welcome you, and they know that you're a valued member of their family. So trust is the main thing. I mean, I can give you an example for my NGO that I started, where I have, as I said, I have students, local students. I don't bring students from the United States. These are local students I recruit during my teaching in the hospitals in Uganda, Tanzania, India, and Nepal. And we're at temples, churches, and mosques every Sunday doing hypertension, diabetes screening. But to start each project, I would have to go to the church or go to the temple, arrange a meeting with the head priest or the head religious leader, and sit down and meet with him or her in their office and explain that I'm a doctor from the US and I'd like to start a project here at your church. I have these students and we're going to set up tables and check blood pressures and blood sugars and to try and help your worshipers be healthy. And the first thing they ask me usually is, so how much are you going to be charging them? And I say, no. This is free, no charge. And then the next question is, well, then who is paying you? I'm like, no one's paying me. I'm here to provide your worshipers with a free public health service because I want your worshipers not to have a stroke. And then, you know, they look at me a little funny, like, what does this American doctor want out of us? And then sometimes they say, are you doing a research project? I'm like, no, I'm not doing a research project. I'm here because I want to help your people be healthy. And after a few more conversations, then I usually go home and then they call me and say, Dr. Chin, when would you like to start your project? You are most welcome. But there's this initial, especially for Western doctors, or especially researchers coming in, like, what's your motive? And once you develop trust, there's amazing doors that open.
Yeah, and I think also from the research side, for me, trust has really been a key element. So I moved to Colombia 4 years ago, and most of my work is actually analyzing and adding to data that have already been collected. So one of the studies I work with has been going on for 23 years, and it's been studying pollution and environmental exposures and child neurocognitive development. And I was really interested in starting to understand cognition in the moms. And I had to establish trust with the PI, with the study staff. And I wanted to understand, well, who are the people that are in direct contact with the moms in the study? And I found out that the study staff have, some of them have been with the study for 23 years. And so just understanding that these are the reason the study is successful is because of that collaboration, and really that the participants and the moms are seen as equal partners as the PIs and the other study staff. Just a note on the importance of interdisciplinary work. I can't think of a project where I don't work with an interdisciplinary team. So I'm not a neurologist, and so I do need to work with somebody who could tell me the complexities of the data we're looking at. There was a question about big data, and I think big data is going to be a really important way forward in understanding more about neurology and health in general. And certainly there are some skills that I have in terms of analyzing the data, but I think one way that where we see a lot of advances is in terms of using medical records. And one area that I don't have experience is with natural language processing. So to look at the written text in those records. And so I think definitely being creative and thinking about who are the different people that you could bring onto your team that could help you answer the question in the best way is really important.
Thank you so much for sharing that. And Dr. Tom, I think we also have another question that may be relevant to your line of work. Benjamin asks, are there any particular situations where epidemiology was able to pick up on subtle trends in neurological disease that originally went unnoticed and may potentially bring insights to the clinical level, kind of approaching the analysis from different means?
Yeah, so thinking back to the use of medical records, there is a very famous example that has been important to the life course perspective in epidemiology. And it actually started out by looking at heart disease and has eventually been applied to dementia and cognitive decline. So there was, I think he was a cardiologist in the UK named David Barker, and he had records of birth weights and other birth characteristics of some patients. And he was one of the very first to establish this link between characteristics of birth and higher likelihood of having cardiovascular disease in adulthood. And so that was definitely an example of how epidemiology has now informed other research as well as clinical practice. So I'll stop there unless there are further questions about that example. But there are, I think, and it goes both ways. It's the epidemiology informing the clinical practice, and then also the clinical practice informing what we should be studying in our epidemiological research.
I'll piggyback on that with the epidemiology with clinical practice, because in neurology, where here in the US, for example, we depend diagnostically on imaging technologies for many conditions, not just stroke or other diagnostics that aren't always available in resource limited settings. Sometimes we do have to take sort of a epidemiological approach and backwards management approach, sort of like, okay, I can't get the final diagnosis, but what are the 3 most common things this can be based on the epidemiology in this region that are treatable, and sort of work our way backwards. Probably why Dr. Chin has TB on his differential every time. But I think that, knowing the epidemiology for a region is so critical, and yet there's a lack of good epidemiological data, particularly prevalence data for neurological diseases in many resource limited regions. The global burden of disease has some data, but it has also many limitations. And so a lot of national, grant work in global health is supporting better measuring the epidemiology of neurological disease as a first step to understand where to focus resources.
Yeah, we should also point out that in many parts of the world, there is no data. There's still probably a majority of countries do not have good birth and death registries. Many people die in low and middle income countries, and their deaths are not recorded, or there's no diagnosis. If you follow the Global Burden of Disease study, which published their new data last fall, the data from many countries is extrapolated from neighboring countries who have good data. For example, Uganda, epidemiological data in Uganda for almost every disease except for HIV, TB, and malaria is pretty much absent, because there's no studies being done. The government doesn't keep good records. So there's a huge amount of just groundwork epidemiological studies that need to be done to know what the true burden of disease is in various parts of the world. So lots of work to do for future global health epidemiologists. I saw a few interesting questions in the chat. Alyssa.
we do certainly have quite a few more questions coming in, but also don't want to push it too much over time. I guess the kind of a bit of an umbrella question we like to conclude with is we're talking a lot about how these different fields are going to be evolving into the future as well. And out of curiosity, what do you see maybe your work looking like a decade later, or what do you see the field sort of pushing towards, transforming into in the next decade?
I'll let Nirali start on that one.
Thanks, Dr. Chen. Well, that's a tough question, and I'll just sort of, it's less global, but sort of a smaller perspective. I was just thinking about the impact of the pandemic and how much more telehealth is being discussed and technology is being discussed. And I can think even, 10 years back when I first went to Zimbabwe, there was discussions about leveraging, telepresence to do better education, capacity building, that kind of thing, as well as research. And the broadband, for example, was not in a place that it would work. And there wasn't internet in the particular locations where we thought it would be useful. But I think, we've come a long way since then, and the pandemic has sort of accelerated us into thinking about leveraging technology more so that, we aren't just having our one-on-one time be when we're physically in country as workers here in a different region, but actually to make that connection and collaboration very consistent without having to waste, if you will, some of the resources through having air travel, et cetera. And while there's nothing to replace being on the ground itself, and I have to emphasize that at least once those partnerships and community is formed, there's probably now, looking to the future, going to be much easier methods to leverage technology to continue those collaborations and move the field forward actively together. That's one thought I had.
I think from a research perspective, and again, if you start reading some of the very provocative commentaries, one that came out of Stanford from Michelle Barry, published in Academic Medicine. You can look her up, Academic Medicine, Michelle Barry, a very important article. In 10 years, I think what we're going to see is instead of the National Institutes of Health and the US State Department and the UK, EU countries deciding what research is done in low and middle income countries, I think we're going to have an international institutes of health, kind of like the COVAX collaboration, kind of like Gavi, where nations, kind of like the Global Fund, where nations are going to be asked to donate money to an international research fund that researchers from any country in the world can apply for a research grant. It's no longer going to be some Americans, I'm going to be provocative and say, mostly white Americans sitting around a table in Bethesda deciding what research should be done in Africa. It's going to be an African university sitting around a table saying, we really need to study this in our country. Let's submit a grant application to the International Institutes of Health. And I think that's the shift that's occurring now. And I think we're going to see this really take off because of COVID making us realize that this is no longer just North deciding what's done in the South. Everybody needs to collaborate and cooperate. So I'm probably going to be retired from all this in 10 years, but it will be interesting to see.
So on the domestic research front, I agree with Dr. Vora that telehealth is going to have a huge presence in research in the next 10 years. At Columbia, we see problems with differential access to telehealth in terms of having a device that can handle telehealth and having stable internet connection. And so that's something that we're working to to establish for all patients for initial and follow-up visits. I think another area that will be important in the next 10 years in research is coming back to the big data and really understanding how we can use different sources of data, both that already exist. So for example, once the census data become declassified, this is at the individual level, it's possible to merge those census data. So I think we'll see more uses of data like that. And I think that it's equally important to think about the possibilities for data, but to also think about the ethics of where are the data stored, who has access to data, and how will the data be used. So unlike Dr. Chin, I'll probably still be working for the next 10 years. So I'm really excited to see what happens in terms of research and clinical care in neurology.
It's really exciting to hear, and I'm sure many of us will hopefully be entering the workforce or maybe still be in school and residencies and postdocs at that time. So fingers crossed that we'll be part of an optimistic trajectory in the future. With that, I just want to say thank you once again, everyone, for joining us here today on behalf of our Journal of Global Health and Simply Neuroscience teams. And everyone, if you could join us in giving a big round of applause, physical or digital, to our speakers today. Thank you so much for your time, on coming in on a Saturday morning and afternoon to spend time with us here. Thank you. Lauren, if you wouldn't mind dropping the feedback form link in the chat one more time. I know we have lots of questions still coming into the chat, and we're a little bit past time already. So please, please submit your questions into this feedback form that Lauren, I think Alyssa just sent into the chat, and we'd be happy to follow up and try to see if we can answer your questions for you. I'm mostly going to go ahead and copy paste some social media links if you're interested in tagging along with any future programming or resources from both of our organizations. We're always happy to be in touch. So with that, I guess we can say goodbye for today. Thank you again. So lovely to see all of your faces.
Great job, Alyssa and the team.
Thank you for including us. It's nice to meet you all.
Thank you guys so much.
Thanks, everyone.
Best wishes.
Take care, stay healthy.
Gonna go ahead and we can stop recording probably.